Thanks, Rachel. And thanks very much, Michelle, for inviting me along. I didn't realise it was actually Women's Health Week, but my first slide here is of Dr. Alice Woodward, who's my great-grandmother. The reason I'm here today is because I am passionate about the New Zealand healthcare system. Alice was the first woman doctor in Auckland, the first woman doctor ever employed by a hospital in New Zealand. She lived where the recreational centre is at the hospital and the university here, so he lived just around the corner. So what's changed since 1900 to now? Well, my two of my daughters are at medical school. They are fifth generation women doctors in New Zealand. My wife's a GP. Alice could actually now come to the Northern Club when she couldn't in the 1900s. Healthcare is way better. We treat leukemia, we treat infection better, we provide a healthcare a lot better. What hasn't changed, and I have all the diaries of my great-grandmother, is when she was working in the costly block at Auckland, she complained that there weren't enough beds, there wasn't enough money for health, and she was told off by the medical superintendent, who was a doctor, that they can't treat people from out of town because they don't have enough money. Nothing has changed in that regard. I've worked through now 7 changes in healthcare, from CHEES to RHAs to now national health authorities over my career. And so what I want to talk about is why we're in this problem, what are we going to do, and some solutions with public-private partnerships. So she had a wonderful saying which goes like this: I do not like the way the cards are shuffled, but I want to play. So through the long, long night, with brow unruffled, I play with what I get until the light of day. The pack of cards has changed now. It's not that enjoyable to work in the public health system as a doctor. And I want to go through that now. So I'm talking about orthopaedics, which is a little red dot up here. It's a very small bit. It's above the water at the moment. My wife's a GP and she works down here with Cecilia and others in general practice. That's under the water because it's sinking. And I'd love to come back here in a few years' time and actually see that iceberg right up the top, because we're never going to cure secondary health care without curing primary health care first. So I'm going to talk to you about the problem in surgery, especially orthopaedics, because that's what I know something about. Why is there a problem? Because we have to understand why there's a problem before we can think about some solutions. So let's look at the surgical patients that are waiting as of the 28th of July. These are hard Health New Zealand figures. For a first specialist assessment in surgery, 191,000 patients are waiting. 77,000 patients have waited over 3 months right at the moment. For surgery, there's 76,000 patients waiting for surgery. Over 30,000 have waited more than 120 days. Orthopaedics is in yellow. This is more important. Look at the trend over the last 18 months. It is getting worse for the 4-month waits to see a specialist surgeon. The wait list is over 4 months is also increasing. The trend is probably more important than the actual numbers. This is an even bigger problem. Planned healthcare has dropped from 15% last year to 12% this year. So we're less productive. And what are the targets? We need to get all this from the minister under 3 months. Why have we got in this situation? Lester always used to show this graph. It's because here's GDP, here's health, here's the difference. It's been getting divergent since 1970. And look what's happening to the life expectancy. The life expectancy is not going away. Look what's predicted in 2053. Everything's getting worse. It's getting worse because the cost of healthcare has increased dramatically. Funding of healthcare has not followed the cost. People are living longer, and we are employing at Health New Zealand expensive, non-productive employees. Infrastructure has also not followed suit. There are too few operating rooms and there's too few beds. This was all present before COVID. COVID has only made this look worse. Look at this. The data is unbelievably bad. This is an OIA that was come out in 2023. Look at this for Nelson Marlborough. We do not operate a costing system and are unable to determine the cost by type of planned care surgical procedure provided in-house. They have no idea what it costs to do an operation in Nelson Marlborough. And that's other hospitals as well. So let's look at the New Zealand Orthopaedic Association. We have a national joint registry. Every joint replacement that's done goes into that. We have incredibly good data. I just want you to concentrate on these lines over here. This is hip replacements, this is knee replacements. These are the ones done in private with private insurance. Red is what's done in the DHB, and green is what's done in the private hospitals for the DHB, outsourced joint replacements. The New Zealand Orthopaedic Association are doing 50% of the work for the public hospital in private hospitals at the moment for hip and knee replacements. So if we didn't do them, you can imagine what the wait list would be. That just gives you an idea of how much has been outsourced at the moment to the private world. We can delve down even deeper into this and look at, for Capital Coast, Wellington, spine referrals have doubled since 2014. This is just for spinal problems. The wait list has increased dramatically for spinal surgery at Capital Coast, and these are the people waiting more than 4 months for planned spinal surgery. And you can see that in Capital Coast, they do 25% of all spinal surgery done down there is done in the private hospitals paid for by Health New Zealand. On top of this, the culture within the hospitals at the moment is at an all-time low. So if you're talking about people and culture within your organisations, that is a huge problem. I've never seen it as low as it is now amongst doctors and amongst nurses. Surgeons want to go in there, do their work and get out of there. No one wants to hang around. The goal of the government is to improve efficiency and productivity in the public system. And I challenge you, how do you do that when your people and culture and values are at an all-time low? Very difficult to do. And at the same time, we need to use private facilities to help us get to those goals of less than 4 months. So I don't know whether you watched this movie recently, but it was Sigmund Freud interviewing Einstein, and Einstein had this great thing that a definition of insanity is doing the same thing time and time again and expecting different results. So what have we always had in the 7 different organisations that I've worked in is top-down administration, always from the top down. Nothing's ever changed with that. It's come through, is it 12, 14, 8 layers of management? I'm not sure what. So everyone talks about flipping it upside down and get the doctors to start running the thing again. Well, I went to the IOD course a number of years ago, and I learned what you CEOs actually do. And I'm incredibly impressed. You have to know something about everything. You're responsible for everything. If something goes wrong, you get your head cut off, and you report to a board which you didn't elect. Some of them are quite odd, and they expect every month for you to report to them everything. Well, that's fine, but if you look at surgeons, or doctors, especially surgeons, we think we know something about everything. We only report to ourselves because we all think we're God. So in fact, that's not the solution. The solution is working together. We have to have really good clinicians who are smart about healthcare, working with smart CEOs together to get the solution. That's going to be the best outcome, and that's what we have to do going forward. The problem is we work in silos. When I try and get some answer, I have to deal with the Ministry of Health, which still exists, Health New Zealand, different political parties. I've been in both ministers' camps in the last few years. And then we've got a whole finance and treasury who fund this. These people have nothing to do with the funding. We have a chief medical officer of every one of these. So who's calling the shots? Within each DHB, I also work in 4 other silos. We have the doctors, we have the nursing silo, the allied health, physio, everything else silo, and administrative silo. And that's how we've got to manage between all those different silos, how we work forward. And if you look at Bruce Holland, I think this is really important, is that these silos are about politics, rivalry, and everything else. It's one of the most frustrating aspects of life in any sizable organisation is trying to work in silos. So what do we do now with public-private partnerships? Well, I work in public, I also work in private. Tomorrow I'm going to be operating at the Starship, today I operated in private practice. Outsourcing, which I've already mentioned, is on a contractual basis. We have radiology facilities that are providing a lot of radiology for the public system. GPs do a lot of skin lesions for the dermatology. Some hospitals lease out their private theatres, which are nursed and managed by the public hospitals in what's called a wet lease. But there's no private investment in public hospital infrastructure in New Zealand. I just want to use ACC here as an example. I must talk to Minister Ducey about this tonight, but ACC is really interesting. They are a public-public partnership and a public-private partnership. They're the most cunning organisation in this country. ACC pays $1 billion to the Ministry of Health to perform their acute surgery, or FAS, every year. They should pay $1.5 billion because, in fact, they underfund the public system. The deficit before COVID was $485 million. We worked out in orthopaedic surgery, if they paid another $500 million, which they should do, we'd have no deficit. They're getting it at unbelievable wholesale rates. ACC contracts non-urgent surgery out to private hospitals and surgeons to do all their other stuff. Hence, they have $46.9 billion in reserve. Pretty good organisation. Minister Ducey works in 3 silos. He's the Minister of ACC, the Associate Minister of Health, and the Minister of Mental Health. One of the biggest problems in mental health is getting acute patients into hospital beds. If as Minister of ACC, he paid his Ministry of Health the appropriate amount for acute care, we'd be able to get patients out of hospital, we'd be able to get rid of some of the low-lying trauma into the private sector, and he'd be able to get his patients from his Ministry of Mental Health into the hospital. This isn't 14 layers of bureaucracy. This is one person with a stroke of a pen who could change the management of mental health and acute injuries really easily. So outsourcing is the government buying clinical services from private. The problem for private providers is it's less income than their private insurance rates. It's very sporadic. It gets turned on, it gets turned off. It gets turned on 3 months before every single election because they want to get the numbers down. It gets turned off shortly after. It's very variable around the country, and political parties and administrators all have a very different view on buying outsourced private facilities. In terms of outsourcing, for the government, it is expensive. It relies on marginal capacity, so what's left over in the operating theatre to fill operating theatres with outsourced patients. The patients have to have a low anaesthetic risk, and there's regional variation, so it certainly doesn't help with postcode inequity. The government wants the private to give back or add some value to the public hospitals by doing outsourcing. Minister Reddy's very keen on this, and one initiative we did last year is we now have private training of registrars in surgery in the private sector. So that is one way of giving back, is doing their work and giving back. So that's a very positive thing that we were able to do last year. What about public-private partnerships and infrastructure? And those of you who are thinking here that you might want to invest in this, I'm not sure it's going to happen too quickly. This is about building hospitals, maintaining them, and then leasing them out. The downside for the government is this is really expensive. So the government can borrow money much cheaper than a big private equity company. So if they can build it themselves, they probably save money. The maintenance and the lease contracts change. There's ongoing debt, and that debt is often uncontrollable because everything changes. If you want to read a very good article on this, Mr. Bagshaw is a surgeon in Christchurch, in the New Zealand Medical Journal editorial this year, this is getting private investment in infrastructure for the government is short-term gain for long-term pain. Public-private partnerships work really well with toll roads. They may work really well for custodial services, Health and hospitals is way more complex than those. My personal view is that I think where the government could partner with private medical companies, people who are wanting to build private hospitals, is the use of land. If you look at Gisborne Hospital here and the amount of land here and Green Lane Hospital, there's a huge amount of land there, which is incredibly expensive, but it's been used for nothing. So why not lease some of that land to a private hospital developer, whether it's Southern Cross, Mercy Ascot, Evolution, whoever it is, or someone new, Infratel, to build a private hospital, but co-locate it with a public hospital, utilising each other's facilities, but predominantly obviously doing private work, but utilising marginal capacity to use it there. I think that may be a solution, and the land price would be very reasonable. So an alternative, and probably in what the government should do when they're building a hospital, is not to get people like me and anaesthetists involved in designing it. What we need to do is actually build highly efficient, cost-effective hospitals and modelled on ones that actually work well. But like going to the lolly shop when you used to pay $1 and get 500 jet planes, I want $1 worth of life. Go to a private developer and say, I want $1 million hospital that's got 13 operating theatres, built in a square box, highly efficient, highly productive. Starship is the worst designed hospital known to mankind. It's an atrium. It cannot be expanded. It can't be enlarged. Let's just get down to the best hospitals I've ever worked in the world are the worst looking hospitals and the most run down. It's the people that make a hospital work. It's not the structure of it. So let's not make custom-made hospitals where every doctor has their say on where the light switch is. They're too expensive, they're unnecessary, and they're often impractical. Unbelievable. What a great hospital. I worked in here as a registrar, opened by David Long in 1984. Built probably to keep George Gere in power and the National Party on the North Shore. When I worked there, we only had 2 theatres open and 2 floors. It was built, everyone said it was a white elephant. It's grown to be the biggest hospital in New Zealand, Waitemata Health. So someone had the foresight to build a very simple hospital with huge capacity for the growth of the company. Back in 1984, we haven't seen one built as well since. So I'm just going to finish with 3 little thoughts, and then I'm very happy for when we have discussion to answer anything you want about healthcare. Auckland traffic. Have we ever cured that? No. So a few years ago, I went and saw my friend Russell Jones. We started school together at Riviera Primary. World expert on traffic. Absolute world. Lived with his mother until she passed away, never married, still lives in the family house by himself. He has studied traffic around the world his whole life. Lester was chairman of Auckland traffic. I asked Russell, what is the solution for Auckland traffic? He said, that's really interesting, Haim. There is no solution. Think of that. He'd just been with Brownlee that morning. He'd just been with the Greens people. It was pre-election, and he's told everyone there is no solution. Has there been a solution in the last 10 years? No. However, when I was looking through my photograph album to find old Russell here for this talk, I saw myself getting the Citizenship Award at Riviera Primary when I was 10 from Sir Dovemeyer Robinson. He said $273 million would give us a rapid transport thing back in the 1970s. If we'd done that, we wouldn't have been in this trouble. So what we need is visionary people like this to transform healthcare. Hopefully Lester can do it. Hopefully, other people may be able to do it, but we need to think differently because it will not continue to work. We're insane what we're doing at the moment because nothing's changing. So my final slide is this, and you mentioned the territorials. This is me here, maybe 19 years old. This is Shane Retty. Don sent this to Shane, and Shane sent it on to me. This is Max Heroini on the stretcher. And I'm thinking about this, and all I can say to all of you, whether you're commercially based or medical based or anything, and we've heard it already today, the patient must remain the centre of everything that we do. But what we need to do is to bring people like Retty and me closer together, frontline versus policymaker together, and get rid of all this middle stuff that's going on so that we can treat this person better in a more uncomplicated way, in a simpler way, and maintain this relationship and work together, policymakers and clinicians, to help this person here. So thanks for your attention.
I'll put you back up on stage actually and take some questions from the floor. Great picture, by the way. That's straight to the pool room, surely. Ladies and gentlemen, any questions from the floor?
Great, that was a lot of fun. Thank you so much. Great, thank you. I'm loud. We'll see whether it turns off on or not. One potential case. One potential case for PPPs. It's a kind of a second best case for PPPs. It seems that nobody who runs the health system ever properly accounts for depreciation in the hospitals. They don't keep track of it. They don't finance it. They don't run maintenance. As soon as the budget gets announced, it all goes into treating patients, and they let the hospital run down because obviously the need in front of you matters more than fixing things that the hospital doesn't collapse in 15 years. Under a PPP where you're leasing, well, you just stop paying the rent if they're not maintaining the service, and the commercial provider then has the discipline to provide it. So if you think that the government cannot help itself but to let the hospitals fall apart, then a PPP is a potential solution. So I was wondering what you might think about that in a second best world. Is it possible to get governments to adequately fund maintenance and not forget about it opportunistically when they've got a tight wait list that they want to hit instead? Or are there's losses either side? Like, what do you think sucks least in the real world?
Well, I think the problem is if you look at the infrastructure that we've got, the maintenance is incredibly poor. So I can tell you that Auckland Hospital needs about $1 billion spent on it just for maintenance. I was operating the other day and the lights went off. We lost all electricity, so we had to stop the surgery. We woke some patients up who were waiting to start surgery because it wasn't safe to continue. That was at the Starship, there you go. So the maintenance there is incredibly poor because every hospital, every year we work in the hospital between 1st of July and the end of the financial year. A few months ago, they put a freeze on everything. They stop outsourcing, they stop re-employing, they stop everything to try and meet the budget every year. There's no interest in maintenance, zero. So the big problem is you talk about increased productivity. This is where people still don't get it. When I operate tomorrow at the Starship, the surgery costs, the implants I'll put in tomorrow, I can tell you, will be $60,000 into a little kit. I can increase productivity and do 2 tomorrow. That'll be $120,000. Increasing productivity, increase cost. So we can't increase productivity without increasing money into the healthcare system. We can improve efficiency, and that could bring costs down because we don't need to employ people for so longer. But if you want to increase productivity within what we've got, it's going to cost more money. No two ways about that. I don't think they've factored that into what's happening. And I can't tell you, you tell me how you increase productivity in your own companies when you've got a workforce who's just completely had enough. Not just because of the hours or anything, but just because of the way you're employed. The punitive way that these hospitals are employing staff now.
Do you have another question? Yes, in the front, in front of you. Yeah.
So
Yeah.
How do you compare the state of staff's mental well-being in a private hospital versus the public system then?
Right, so private hospitals, well, I can talk from Mercy Ascot, is well staffed. It's happy, I have the same team, and generally fairly positive, yeah. And, you know, in different pockets around the country as well. I mean, Starship has survived this whole rundown well because, people are passionate about working there. It's kids. It's a smaller hospital than Auckland or South Auckland. I mean, South Auckland, Middlemore Hospital is my favourite hospital in Auckland. I loved working in that place. That place is just the God's end of the world. It's just wonderful. And people are great. It's diverse. It's everything. No one wants to work there now. That was my favourite place. And little things, I have the greatest team at the Starship in the operating room. We do 10-hour surgeries. Those people stay there all day. They work late. They miss their eyelashes getting done and their things. You know what I mean? I mean, it's incredible. They stay there. But some local manager says that the charge nurses of theatre are going to get paid less than the charge nurses on the ward because it's not the same responsibility. These stupid decision-making by middle management that just run the morale and everything down of the people. Do you know what I mean? You can't run a place like that. And how are you going to increase that efficiency by treating people like that? I've got no idea.
Nick Estwick, I guess that's probably the concern that we look at is Leicester's not going to achieve his objectives unless the enablement and empowerment of the workforce is regathered. Obviously, that's what the sort of centralisation of decisions. I talked to Orthopaedic. They've got a fourth-tier manager somewhere in Te Whātua to change the clinical pathway of care, for example. So do you think the whole devolution of leadership is still fundamentally necessary to enable and engage the workforce at the front lines?
Yeah, so Nick, I'm a great fan of centralised Health New Zealand thing. So I'm a great fan of what the last government did to centralise that, to get a single electronic pathway, to get procurement, all those sort of nationalised things singly. I think it's a really good thing. I think you do need to have local leadership because it's just too far. You've got to need to negotiate early. And that with Southern Cross, or certainly with Southern Cross hospitals, New Zealand Orthopaedic Association, we work with you guys. You're a national thing, but locally and stuff to do whatever. So I think the 4 commissioners will work well, but I think the key for me will be the local commissioner for this area is Mark Shepherd. Mark does a good job. He needs to work directly with clinical directors within the hospital and the 8 layers in between that thing. Now, we heard about 12, 10, 8 layers. Okay, so it doesn't matter whether it's 10 or 12, but if I decide tomorrow that I want to change something in the operating room, I want to do something, we're a national thing for spinal surgery, let's say, well, I can tell you, I do spinal call at the Starship for 25 years on no contract, no pay, no nothing. They ring me on a weekend, I just go and fix up some paralysed child because no one's ever bothered to give us a contract or do anything. But anyway, if I wanted to change that tomorrow, I'm just a lackey there. I'm no different from every other, I'm B2 surgeon, right? I'm not even Haemish Crawford, I don't think. So I turn up tomorrow and do my list and I go, I'm sick of this. This person's come from somewhere paralysed and fixed me. I've got to change this. I need to talk to my clinical director, who's an orthopaedic surgeon, who then needs to talk to the manager of surgery. So let's start here. There's me, clinical director I have to talk to. He'll talk to the manager of surgical services, who'll talk to the manager of Starship. Manager of Starship then needs to talk to the person at Auckland City Hospital, because we're under that, who then needs to talk to Shepherd, who not Mark Shepherd, but the other Bat Shepherd, who's the CEO. So that's 5 people before we get out of the hospital. He needs to talk to the regional director. The regional director needs to go back to Te Whātua. They need to talk to Duncan Bliss, who was here earlier, who needs to talk to Fiona Duggan, who's just lost her job, who then will talk, probably doesn't need to talk to Margie Arper, but needs to talk to the minister or someone else to get the thing. Fiona can sometimes make the thing. So there you go. That's me, 9. So whether Luxon says 14 or 12, who cares? It's got to then go up through his silo anyway, right? So that's another 5 people. So to Treasury. So it's not rubbish. It is what happens. That's what happens.
Just one final question here.
I hope it's not all sounding too depressing. I totally love my job and my 2 children are doing. I just tell them keep out of all this fanfare. Just do your job. most unbelievable profession you can ever do, looking after people. But we have to keep the quality. This is an amazing healthcare system. ACC's even better. So is our healthcare system. We've got to keep it going. You know, it's been going for a long time.
Quick question. What would we take from what they're doing in Australia to bring over here that could help? The only reason why I say that, I'm an insurance broker and we have clients that are using services in Australia using New Zealand policies.
Oh, wow.
And we see a significant difference in the cost of what it costs to have procedures done here than what it does over there. And I'm not an Australian advisor. I don't know why. What could we do differently here that works over there? Is there anything?
To bring the cost down.
Yeah. Is there a reason for it? Numbers of people?
Well, they work under a different system, the surgeons over there. I mean, I can only talk from my very limited scope of what I'm understanding what they do. So we have no co-payments in New Zealand. Let's say, I'll use an example of a joint replacement. Right, Nick, here's the CEO of Southern Cross Healthcare. I mean, we work with Southern Cross. I mean, New Zealand Orthopaedic Association partners everybody. I mean, you know, if you've got a patient, the partnership is this. The insurance company, NIB, Southern Cross, whoever, or ACC, the hospital, the surgeon, the anaesthetist. Everyone has to make a living and provide high quality care for the patient. Now, we need to keep our fees down because we need to keep the insurance costs down, which keeps 33% of New Zealanders in insurance. We need to try and increase that. We now have affiliated provider stuff where we have a set fee. So if I see someone who needs a knee replacement, I don't even know what it costs, to be honest. It just goes to Southern Cross or NIB and it gets all signed off and we get a certain fee and it's all done, right? In Australia, if some incredibly wealthy person comes in, I just charge a surcharge on top of that. So you know, you can charge $20,000 surgeon's fee for a hip replacement over there if you want. But we can't do that here. So what you're buying over there from someone is different to what they may buy themselves or what the surcharge is or whatever. So their surgeon's fee for doing an insurance case or whatever might be really low, and some of the other factors might be low. They may even use a cheaper implant. But if someone comes in with a lot of money, I tell you what, it's a whole different story. So hopefully you're buying good quality there. I'm sure you are. They're very good. But we don't have that same difference in quality. Do you know from our... Does that make sense? So if you look at our joint registry, we have fascinating data from this. If you have a hip or knee joint replacement in a public hospital, maybe done by a trainee with a surgeon there in Auckland Hospital, any hospital in New Zealand, or you go and have it done in private practice by me personally or some other surgeon personally, the outcomes, and we do PROMs, so patient-reported outcomes, and longevity is identical. How amazing is that? The same quality of care in the public hospital as the private hospital for total joint replacement. I think it's amazing. We're so lucky. So people who don't have insurance are getting the same outcome. They just have to eat that horrible food at Auckland Hospital and share a room, some poor old lady with 3 men, you know. But it's good outcome.
Dr. Haemish Crawford, very much appreciate. Thank you very much.